Dr. Nuelle, welcome to the Nailed It Ortho podcast. We are happy to have you on. So welcome.
Thank you, guys. Thank you for having me.
No, again, thank you for being a guest. And I'm excited about today's topic, a little bit of cartilage restoration. And we'll talk a little bit about some type of OCD lesions. But before we get into all that, we kind of generally start with a couple of questions, just getting to know you as a person. And so the first question I have for you is what brought you into the field of sports, or what made you choose that as far as your specialty?
Yeah, sure. So I think similar to a lot of folks that go into sports, I played a lot of sports growing up and was an athlete growing up and had some different injuries and things like that. And so that drew me to orthopedics first in general. And then once I kind of got more involved in sports and got able to be involved in kind of coverage with team stuff and being involved with different types of sports teams and those sort of things, that drew me directly to it pretty quickly. And so I was always interested in ortho and always interested in sports in particular, and a number of different type of procedures that we're able to do arthroscopically and minimally invasively via that route definitely drew me to it. And so it's definitely a field that's enjoyable, and it's kind of ever changing and always new technology coming out. So it kind of always stay on the learning curve, so to speak. And so those types of things are really appealing to me.
Nice. Yeah. It's definitely a lot. It seemed like there's always a lot going on in research when it comes to some of the sports topics and, just kind of new and updated techniques that's always coming about. So I can definitely understand that. Since we're talking about that, the next question is actually what would you say is your favorite case and why?
Yeah, so I mean, I think any sports guy wouldn't be a sports guy if they didn't say that they like doing ACL reconstructions. That's kind of almost the bread and butter for any sports person. And you mentioned research, and the ACL is the most researched ligament in the entire body. So we all have to love ACLs, of course. But the topic we're talking about tonight is definitely my favorite. It's a bread and butter for me, and any type of cartilage restoration procedure I really enjoy doing, particularly osteochondral allograft transplants and matrix-associated chondrocyte implants. And so cartilage restoration is something that I really love, and I think it's really enjoyable, and a lot of changes going on and a lot of research, as you alluded to and mentioned. And so I think it's a really interesting kind of subfield within the field of sports medicine and arthroscopy.
Yeah, I think that's pretty cool. I actually got my ACL reconstructed when I was a little bit younger, so I do enjoy a good ACL case. So moving on to the next question is, so what made you, because sometimes we have a lot of residents that listen in on our podcast, some chiefs that may be going about their own general field, and they're trying to figure out what kind of practice they want to go into. So what made you choose, I guess, your type of practice, or what kind of drew you towards that? Like what was your decision making?
Yeah, that's a great question. That's a big question, certainly, and you could get very 10,000 picture and say that I wanted to practice where I could do some sports medicine and cover some teams and hopefully have a wide range of things that I cover, where you get very, very specific in terms of the bread and butter or the specifics of the practice itself. In terms, I'm personally in a private practice, but then I also have an affiliation with the academic university, and we have fellows and that work with us, and occasionally other residents from one of the local residencies here in town, and medical students too. So almost kind of like a private demic, people like to call it sometimes. And so I enjoy that a lot because I get some of the benefits of some of the autonomy of a private practice and working in a surgery center in a private practice. But then I also get the benefits that I enjoy too of teaching and working with residents and fellows and medical students, and then research and the research aspect of it, and being involved in that as well. And so I think for me, it was being able to have a nice combination of autonomy and the type of practice setup that I wanted, and the type of environment that I wanted, but then also still being able to be involved with fellows and residents and medical students and involved in research and societies and those types of things as well. And so I definitely would say find the setup that fits your personality the most, and the type of group or the type of location or the type of hospital that you think really you would enjoy working at first and foremost, and then other things play a role too in terms of location and family and things like that, obviously, as well.
Absolutely. Yeah, I think that's one of probably the earlier things that you kind of have to decide is Do you want to go into more of a private type of practice versus academic? And, all those things that you mentioned about, enjoying being able to teach and being involved in research are some of the things that probably help the most. Um, but we're gonna go ahead and get into the talk today, and this today's talk is kind of is actually a big topic, and that's kind of how we wanted it to be. We're going to talk about OCD lesions, but we have a bit of a case to have everybody on the right mind track of how these people sometimes present. And this particular person will be an athlete, but it's not always an athlete. But uh, we have a 18-year-old football player who comes in with a 4-month history of generalized knee pain. Say that it first started about 4 months ago and seemed like it got better for a little while, but it still bothers him with practice and when he's playing the game. Certain movements seem to really give him a lot of aching pain right at his knee. Um, and let's see. Yeah, so pretty much where would we start with something like that as far as history and physical and trying to work up someone to evaluate whether or not this may possibly be a OCD lesion?
Yeah, so you touched on some of them, the duration. Some of the big things that are important are, is it activity related or is it all the time? So, does it only happen when he runs, or is the pain starting to occur every single day, every time he takes a step or every time he walks? Has he ever had issues with this before? Did he have issues with this when he was younger? Did it just start within these last few months? And, has it come on and has it worsened over that time? Are important types of history. Does he have any type of family history of any sort of congenital issues or any sort of any family history of any other type of arthritic issues or cartilage type of issues within the family themselves? And then certainly from the physical exam standpoint, big things are joint effusions, especially at that age. Anytime an adolescent, you want to know if they have a joint effusion, because if they're having recurrent joint effusions, then something's happening intra-articularly and something's going on that should tip you off if they're having recurrent joint effusions. And then from the specific physical exam standpoint itself, where's the pain? Where's it located? When does he get it? Does he have any evidence of any sort of catching or locking or crepitus within the joint with range of motion? And then, is there any sort of tenderness to palpation? And it depends on the joint that you're talking about. This is a football player, you said, in the knee, correct?
Yes, sir.
Yeah. So a lot of times they'll have pain, tenderness to palpation, over one condyle or another with deep flexion, especially if it is an OCD and if it is located on one of the condyles, which is what's most common in this age group or that age group for an OCD. So you'll do your kind of typical range of motion and ligamentous exam, but sometimes when you put them into deep flexion and you palpate one condyle or another, they'll be focally point tender over a certain condyle, and that'll kind of clue you in that they may have a localized defect or a localized lesion on one condyle or another.
And so this particular case, we made this about an athlete coming in with knee pain, but what's some of the other areas of the body that you have to kind of consider possible OCD lesions, and I guess how would they present as well?
Yeah, great question. So, the knee is one of the most common, certainly, and then followed by the elbow, and then the ankle is another common one. You can get OCDs in most joints, but then certainly the knee, elbow, and ankle are the three most common. Knee being most common that you see just in general, but then specifically they'll present often like you presented in an athlete, like a football player or a runner of some sort. Elbow can present in a variety of ways as well, but most frequently you'll see it in a gymnast because obviously they're doing handstands and things like that, and so they'll become symptomatic. And then an ankle can present in anyone certainly as well, but often we see those in running type of athletes or frequently often in ballet dancers, and then sometimes soccer players and things like that. But especially ballet, you may want to kind of be tipped off to a talus OCD lesion in the ankle. And so those are the three big joints or most common joints that you're going to see in OCD, particularly in an adolescent or even someone in their potentially 20s and 30s. And for the knee, it's most common that it'll occur with weight bearing or with running, that the pain will occur, or at least that's how it initiates. With the elbow, it's same thing. If they get kind of weight bearing, like they're doing handstands at a gymnast, or they get it can sometimes occur in a thrower as well. If you have a pitcher that puts a lot of stress with a lot of valgus stress on the elbow and a lot of stress on the capitellum in particular, which is where you most frequently see it in the elbow. And so those are the most common areas, or I should say the most common joints for OCDs in particular.
And
And
oh, I'm
I,
sorry,
no, go ahead.
Wendell. I was just thinking about this because I don't really know if this is high yield for questions, but it's definitely high yield clinically. As far as like OCD lesions, and I was thinking about the ankle. You also see it, or I've seen it at least, in patients who this is just like the common everyday person that had a some kind of ankle sprain or a mild ankle fracture, and they still having this continued pain months down the line, and later on you find out, you may get an MRI or something like that, and you find out like, hey, they have a OCD lesion. So I think that's another little key
Yeah, I've seen
to,
that
I
too.
guess, kind of tie into things. Yeah, because it could be a good question, right? Why this person with who had this ankle sprain or ankle injury still having pain after physical therapy and such, and something to keep in mind for sure.
Yeah, no, I think that's a great point. And Dr. Nuelle, just to continue on, so I guess we never really defined what an OCD lesion is. So can we one define what an OCD lesion is, or what osteochondritis, osteocans is, and then can we kind of go into what we look for on the X-rays for these patients um, that have these lesions, or what are you even ordering X-rays, or are you just jumping to MRIs, and can you kind of talk about that?
Yeah, sure. So OCD, as you stated, osteochondritis dissecans is can be, it's an abnormality or an abnormal development of particularly the articular cartilage, and then typically the subchondral bone that's attached to that articular cartilage within a joint. It can happen for a variety of reasons. It can be a congenital malformation that it just never fuses or never develops appropriately. It can be from a traumatic defect or traumatic injury, as you guys just stated, which happens frequently in the ankle, but can happen in the knee or elbow or other joints as well, where we see these defects. It can be relatively idiopathic, where it develops from some sort of other pathology that's associated in the joint, or a repetitive injury to or microtrauma to the joint as well. And so those are the most common etiologies of it. In regards to the imaging, we definitely get X-rays, and certainly X-rays in general for joint evaluation, or whether it's be an injury or just symptomatic pain is first line. And in this case, it definitely would be the first line as well, because X-rays will really give you a really good view of the anatomy and the outline, potentially of the OCD defect. In particular, if it's in the knee, if we're talking about the knee, the standard kind of views that we get, for knee X-rays would be a weight-bearing AP, weight-bearing lateral, an infrapatellar, or what people will term the sunrise or merchant views, and then a weight-bearing PA 30-degree flexed. So people call that often the Rosenberg view.
Yes,
But
sir.
basically, the patient bears weight, flexes their knee 30 degrees, and then it's a PA view. And that view is actually the best in the knee for the most common OCD lesions, because most of the time the OCD lesions that you're going to find in the knee are going to be on one of the condyles, like I said. And the most common location for an OCD lesion is typically kind of the lateral aspect of the medial femoral condyle. So if you're looking again at that weight-bearing flexed view, that's where you're really going to see that OCD lesion on the lateral portion of the medial femoral condyle, because oftentimes it's a little bit posterior too. And so that flexed view is really important, especially if you're thinking in your mind that this patient might have an OCD lesion, and you want to get a really good visualization of that OCD lesion just with your initial imaging in clinic with radiography with X-rays.
So at what point do you move to switch on the MRIs, right? So if we get an X-ray and we see, for example, in the knee that we have a defect in the medial femoral condyle, do you jump to an MRI, or do you undergo some like non-operative treatment first, and if it doesn't get better, then jump to an MRI? Like, in what case are you doing that?
That's a great question. And so that's where it gets back to your history and physical exam, as you guys had a great question earlier. And so a lot of times it depends on the patient age, and then correlating with their history and physical exam. So if a patient is younger, and then you see on their X-rays that they're skeletally immature, so their physes are still open, and they just have a moderate amount of pain, then that patient is often initially treated non-operatively. And so non-operative management consists of kind of the usual anti-inflammatories, maybe some physical therapy, and in this case, typically some sort of activity modification where you definitely take them out of sports if they're doing that, and then oftentimes restrict their weight bearing to some degree with partial weight bearing or even toe touch weight bearing for a period of time on crutches. In the olden days, we used to actually, in the younger kids, we used to actually even put them in full leg casts because nobody trusted young kids to not walk on their legs unless you put them in a cast, and that was
Still
kind of the
don't.
old, yeah, right. And so we don't often do that as much anymore. Put them in full leg casts for OCD because a lot of the literature shows even if you just try and keep them off it or keep them out of sports as much as you can, and their physes are open, they'll still probably heal in the majority of cases. So we don't do that quite as often as we used to, but anyway, so that's kind of the initial treatment in that particular patient. In the patient that you gave the case example at the beginning, an 18-year-old male football player, highly likely that his growth plates, his physes are going to be closed, and he's had 4 months of pain and swelling. And so that patient is, you're probably going to see, if it's an OCD, which is what we're talking about, you see that on X-ray, it's a high likelihood you're going to then go to an MRI in that patient because his physes are closed. And even if you do non-operative management for a period of time, you kind of want to characterize that lesion pretty well, especially if he's, like in the example given, if he's in like his senior year or if he wants to continue playing football, you want to have a pretty good characterization of what that lesion looks like on MRI so that you can counsel that patient accordingly if non-surgical management may be an option for him or if he may end up needing something further down the
Right.
Okay.
And I know we're talking about the knee, but what are some and I think you touched on the fact that some of the most common areas for these lesions are going to be on the medial femoral condyle and the lateral aspect of it. But just to quickly touch on elbow and ankle, what are the most common areas for a lesion in those areas of the body?
Sure. So elbow is most commonly in the capitellum. And so a lot of times kind of like that lateral kind of aspect of the capitellum. And again, most commonly we'll see that present in gymnasts. Doesn't have to be a gymnast certainly, but most commonly in gymnasts just because they're weight bearing on their elbows. And then in the ankle is most frequently the medial talus, and it's kind of the central to sometimes central to posterior aspect of the medial talus. And you guys made a great point that oftentimes we see that just in traumatic patients as well as in, kind of the congenital or type of setting. And so those are the most common locations in those two most common other joints. The knee tends to be where we see the biggest lesions, not only because the articular cartilage and the articular surface is the largest, so there's a larger area for it to encompass, but it also tends to be where you see kind of some of the bigger defects and bigger lesions as well. And so the knee, depending again on the type, exact patient history and physical examination and radiographic findings, the knee sometimes tends to be less amenable to non-surgical management, at least especially as compared to the elbow, because again, unless they're a gymnast, the elbow is a non-weight bearing joint. And so that's often very amenable to, or more so amenable to non-surgical conservative management, which we discussed earlier. The ankle kind of just, again, depends on kind of their activity level and the lesion characteristics itself.
Okay. And so we're going back to, some of the imaging as far as when we're looking at the MRI, and I guess we can go back towards the knee case that we had earlier. What are some of the things that we're looking for on the MRI, and what kind of helps you determine about stability of the lesion?
Yeah, great question. So that's a huge thing, as you stated. So is it a stable versus an unstable lesion? And so the stable lesion is one where there's not going to be a significant amount of subchondral edema, or in some cases even fluid beneath the articular surface or beneath the subchondral portion of the fragment, of the OCD fragment. If you start to see pretty well circumscribed area below the defect, or even in the buzzword that they often say on the boards or say on the OIT and stuff is fragmentation, if it's a fragmented defect or fragmented lesion, which sometimes you can see on X-ray, but sometimes not. More frequently, you can see it better on MRI. Is fragmentation of the lesion. Then you start to worry that it could be more unstable, and then certainly in some cases you can actually see a lesion become an actual flap or become loose or free floating, which is straightforward then, of course.
Right. So again, just to summarize that, so you said for our unstable lesions, those are the lesions like on MRI, you may see fluid that goes underneath that lesion. if it may be fragmented, or if you see a flap. And I know you mentioned a little bit earlier about the fact that our patient whose physes may be closed because he's 18. What does that have to do regarding, like, what role does that play regarding stable versus non-stable lesions if the physis is open or closed?
Yeah, just more commonly, if the physis is open, it's going to be more of a stable lesion more frequently. It's not going to have detached, or it's not going to be fragmented as much if they're still going through periods of growth with an open physis, and then more commonly it'll be classified, or it'll appear on your imaging as an unstable lesion if they have closed physes.
Right. Okay. And I think you spoke about it a little bit earlier, but so for our stable lesions at first, you were saying that we're going to treat those non-operatively, and that's where you were saying we would be doing things like, activity modification, taking them out of any sports for a little period of time, NSAIDs, and then eventually going on a physical therapy. Um, I think we spoke about it. Do you repeat, like, for example, if the patients are getting better with your treatment, do you repeat MRIs to keep an eye on the lesion over time, or do you just go clinically, like if they're feeling better, you don't repeat anything else after they've done their period of non-operative treatment?
So initially, we typically, first and foremost, we would repeat X-rays, particularly if it's a defect that's easily visualized on X-ray, and so that's obviously easy to do, less time, less cost, those sorts of things. And so we would repeat X-rays about every 4 to 6 weeks or so, until the lesion is either healed or mostly healed, and the patient is completely asymptomatic both on history and physical exam. Generally speaking, in terms of a repeat MRI, we would typically do that if the patient remains symptomatic, or if the X-ray looks good and you start to let them become more active again, but they become symptomatic again, then you would repeat the MRI. Typically anywhere from 3 to 6 months after the initial MRI or after the initial diagnosis.
Okay. Well, and I guess that kind of leads to it. But what are all of the kind of operative treatment indications that you look for that's going to definitely tell you, okay, this patient definitely needs surgery?
Yeah, so that's a great question. And so again, it's a case by case basis. And so we lined out kind of some of the main factors in terms of it being an unstable lesion with closed physes, and typically, so that typically means a little bit older patient, generally speaking. And so, depending on the lesion characteristics and the lesion size, and the patient activity level expectations, and then age and that sort of thing, will dictate the degree of, or I should say, the amount of surgery that the patient's going to require, or the amount of restoration that the patient's going to require. Certainly, first and foremost, the easiest thing is a simple, and when we start going down the surgical road for those type of unstable lesions, or for stable lesions that have failed significant non-surgical management. So either one of those could be the case. The first and simplest thing is a simple kind of arthroscopic debridement, or removal of any sort of flaps or any sort of unstable portions of the defect or lesion that could be causing mechanical pain, or could be causing um, a flap kind of injury, or flap tear, or loose articular cartilage. That's the most simple and kind of straightforward thing. I would say that generally speaking, that's not the most common thing that gets done. I mean, it's the simplest thing and easiest thing, and sometimes it's what gets done. But generally speaking, in these types of things, if we're moving towards surgery, or moving towards doing surgical management because it's an unstable lesion, and because it's a severely symptomatic, even stable lesion, we're going to be doing something to try and address the lesion, whether that is some sort of drilling, or whether that ends up being fragment fixation, or whether that ends up being actually a full-on cartilage restoration procedure of some sort. And so most commonly, we're gonna, if we're operating, it's gonna end up being something slightly more involved, or more aggressive, I guess you could say, than a simple debridement in most cases.
Yeah, I think that was great. And you mentioned drilling. I think we can go ahead and kind of just move into some of these, marrow stimulation techniques. And so can you touch on, like, arthroscopic microfracture slash drilling, like what patients are are what patients is this indicated for? And then, like, what is the procedure? What kind of healing does it involve, and how do you know that you're doing this right?
Sure. So there's all different types of things that encompasses. And so The quote unquote drilling that people typically talk about, there's two different types of drilling. So there's antegrade, which typically is also referred to as transarticular, where you actually drill through you actually make an arthroscopic portal or even a mini open portal, and you drill through the defect or through the articular cartilage into the base of the defect. And then there's retrograde drilling or retroarticular, where you actually come in from the side of the condyle, if we're talking about a condyle, and typically under intraoperative X-ray fluoroscopy with a C-arm or something like that, you actually drill underneath from the side of the condyle, underneath the defect to basically just beneath the subchondral plate or subchondral bone. Both of them are obviously, the intention is to perform, as you stated, marrow stimulation. So to stimulate bone marrow, to stimulate growth factors and bone marrow aspirate from within the bone marrow itself to the base of the defect, to stimulate some degree of healing capacity and growth capacity to the area that was otherwise not developed well, or that created the defect. And so those are the two most common kind of ways that people have described drilling of an OCD defect. Again, either antegrade or retrograde type of drilling.
And is there a size, like, is there a certain size lesion that you would do this for? Like, is there, like, you'd say you do this up to like a centimeter lesion, or is this your first, or your first option, or your first thing that you would go to for most lesions? Like, how do you decide, like, okay, let's try microfracture, or let's try drilling with this patient versus something else?
Great question. And so there's two main factors that are involved in it. Number one is age. Well, three main factors. One is age, two is their skeletal maturity or thereabouts, and then three is the size of the defect. So, and then obviously age and skeletal maturity kind of go together. So if it's a younger patient with a relatively smaller defect and their physes are closed or almost closed, or even if it's a stable defect but they've failed significant non-operative care, and so it's now a symptomatic stable defect, as we stated, those patients are the ones that are typically going to be indicated for some sort of drilling, whether it's a transarticular or a retrograde technique, because they're going to be much more likely to be able to heal that defect potentially. If it's an older patient who then is definitely skeletally mature, so a lot of times we'll get some of these present with patients in their 20s and 30s and that sort of thing even, and it's a bigger defect, typically anywhere from around 2 centimeters or so, two centimeters squared in terms of the defect. So if it's older and larger, those patients don't do as well with any type of drilling, no matter what type of technique you utilize, just because the articular cartilage or the overlying articular cartilage is really typically pretty poor. And so it's no different than if you saw a patient with a traumatic defect of their condyle or their patella, and then, or even to some degree a degenerative one, and you just performed a regular microfracture on that patient. The literature is pretty clear that also doesn't do well in that type of patient either, and it's a pretty similar type of patient population at that point. And so a microfracture or any type of marrow stimulation or drilling type of technique, however you want to term it at that point, is not going to do very well long term in that type of patient. And so younger and smaller defects are what is going to be typically indicated for some sort of drilling procedure in isolation or in combination potentially. And then older and much larger defects are going to likely get some form of formal cartilage restoration procedure.
I think that's great, because I always wondered, how people decide, because there's always these different options, and I'm always like, I mean, if this is an option for everything, how do you decide who gets what? So now I'm super glad that you just went through that. Our younger patients with our smaller defects. Now I know there's some other techniques as far as osteochondral autografts versus allografts. Can you kind of touch on both of those and what it is, patients that are these are going to be indicated for, and just kind of educate us on that?
Sure. So osteochondral autograft is obviously taking it from the patient themselves, from a different location. Since we're talking primarily about the knee, if you're taking it from the knee, you typically would take a plug or some amount of autograft bone and cartilage, oftentimes from either the intercondylar notch, if it's a smaller plug. So in the intercondylar notch, you can take it just above or anterior to the ACL. Again, as long as your defect doesn't encompass that or isn't close to that type of that location, or you can take it superior and proximal and lateral to the lateral trochlea, is the typical locations where you harvest an autograft, osteochondral graft. And so that's typically indicated for smaller defects. Certainly you can't rob Peter to pay Paul. And so frequently we don't take what people have termed an OATS, osteochondral autograft transfer system, which is OATS. People don't take an OATS for much larger than about a 10 millimeter or a 1 centimeter defect. You can take multiple plugs to try and cover a larger defect if you needed to. But obviously, like I said, you can't really rob Peter to pay Paul after you take a certain amount of autograft cartilage. And so, the osteochondral autograft is certainly one option, but it's a pretty limited option for smaller defects in the knee. In the elbow, osteochondral autografts are a terrific option because again, the joint surface area is smaller. Yep, exactly. And so, if you have even if it's a big capitellum lesion in the elbow, that's it's big for the elbow. A centimeter for the elbow is huge. And so oftentimes you can take an autograft from the knee actually in those same locations we just mentioned and then plug it into the elbow. And so frequently for the elbow, if we need to do cartilage restoration or some sort of graft, it is very often that it's an osteochondral autograft, and we take it from the knee and we plug it into the elbow. The talus, as we mentioned the ankle earlier, the curvature, radius of curvature of the talus is pretty hard to match. And so you can take one from the knee and put it in there. It's been done, but it tends to not really match up very well just because no matter where you take it in the knee, the radius of curvature of the articular surface is going to be different than the talus. And plus it's a little hard to get into, especially if it's a central and posterior defect. You a lot of times have to do like a malleolar osteotomy or something to even get into it, to get it in and put it in place. And so that's a much more technically demanding type of procedure for the ankle, doing an autograft transfer of that sort in the ankle.
Right. And what about the donor side morbidity? In patients that are, like have like large BMIs, do they tend to do, I assume they would tend to do a little bit worse if you're getting an autograft or harvesting one from their knee. What have you seen as far as the donor side morbidity? Do you see that patients don't notice it, or you feel like down the line they do? What are your thoughts?
Yeah, in general, it's like most things in orthopedics and medicine in general. Patients with larger BMI and then patients who are older tend to not do as well. Just again, that's very generally speaking, of course, but that holds true here in this case too. I would say for the autograft transfer, like I said, these are relatively small plugs that we take, and so we can be fairly aggressive with those types of plugs, and patients generally do pretty well, but certainly and have pretty minimal harvest site morbidity, again, generally speaking. But as a general rule, patients with a larger BMI and patients who are older, particularly older than 40 or 50 or so, do not do quite as well.
So, it looked like we've been, talking about some of the options for smaller defects. What are some of the things? Well, yeah, what are some of the options for larger defects, and what options are you looking at for those types?
Yeah, so my favorite procedure, probably maybe of any procedure, as I mentioned at the outset, but certainly one of my favorite procedures for larger defects in older patients in this type of setting with this type of pathology is the osteochondral allograft transplant. And so that's where we take live cartilage and subchondral attached to its appropriate subchondral bone from a donor, and then that gets harvested, and then we size it appropriately to the size of the defect of the patient, and then we cut it to the exact dimensions, and then we implant it into place. And it can be implanted with a number of techniques, but typically implanted with a press fit type of technique where it's implanted perfectly line to line essentially. And so that's a really great technique and a really nice surgery, and there's a lot of really good literature that's come out now, 10 to 15 year follow-up, that shows that it's an excellent option for OCDs in particular, because OCDs, we know a lot more about the natural history of them now than we did even 20 years ago, even though we still don't know everything. But oftentimes, in addition to the articular cartilage not being good and not being healthy, the subchondral bone is also usually not very healthy and is not normal. And so the benefit of an osteochondral allograft is you're transplanting, living healthy articular cartilage and subchondral bone, and you can regulate the depth of how deep you want that subchondral bone to go. And so if you get your preoperative MRI that we discussed earlier, and you see bone marrow edema or a defect that goes 5, 6, 7, 8, even 9, 10 millimeters deep into the subchondral bone, you can ream out all of that unhealthy subchondral bone and then replace it, with a large osteochondral plug if you needed to.
Nice.
Now, I guess how about the storing of these allografts? Do you at your facility, are there any special procedures, or is there a shelf life to how long these allografts can last for? And then what are some of the downsides for using osteochondral allograft?
Yeah, that's good. That's a two-part question. So first part is the storage. So historically, these had to be stored in a certain type of storage medium that keeps the chondrocytes alive, obviously, and keeps the chondrocytes living. And there's been different types of storage mediums that have been developed over the last 20 years. Historically, the mediums that were utilized, the graft would start to lose chondrocyte viability after about 28 days or so. So the minimum, obviously, chondrocyte viability that you need to implant one of these transplants is you need to have at least 70% chondrocyte viability. There's been numerous studies that have done in the literature that show if you have less than 70% chondrocytes, it's going to not do very well. It's going to fail long term. And so you have to have at least 70% chondrocyte viability, but ideally you would have 100% chondrocyte viability, or at least greater than 90%. You want normal cartilage, you want normal chondrocytes. And so historically that's been about 28 days. The grafts have to go through rigorous testing to make sure that obviously there's no types of bacteria or viruses, but then also that the graft is structurally appropriate, and that testing typically takes about 14 days. And so historically we would get notification that we had a matching graft available for transplant, and you would have anywhere from maybe 7 to 10 days, oftentimes, or if you're lucky, 14 days to implant it into the patient. And so that is one factor, depending on the tissue bank and the tissue storage medium that's being utilized. There is a new preservation system that's been developed, actually where I trained, is where the preservation system has been developed. It's called the MOPS Preservation System, Missouri Osteochondral Preservation System, MOPS for short. That is actually a pretty cool thing. That's really changed tissue transplantation for these types of grafts. It now allows grafts to be stored for up to 56 days with 90% plus chondrocyte viability.
Oh, wow.
And so that's really changed. That's changed the landscape for osteochondral allografts. And so now we have many more grafts available. And then we have them available for longer. So we don't have to now call the patient and say, hey, you got to get here and we have to do your big transplant surgery in the next 5 days. We can say, well, we can do it in the next 25 days. And that makes it a little bit easier on patients and on surgeon scheduling too, obviously. So that has helped. And so that's a long answer to part one. Part two, your question was still limitations. So limitations, they still exist even with the newer MOPS preservation system. So it still costs a fair amount of money. So cost is certainly one limitation versus some other things. Depending on the preservation system or the transplant company or the size of the patient, if you get a patient that's 6'8" and 300 pounds, it may be hard to find a matching donor graft for him. And the same thing on the other side. If you have a gymnast that's 4'10", you may not be able to find a graft that matches her. So availability. So availability is a big one. And then anytime you're using an allograft, even if it's done perfectly and done well, there's always a risk for potentially lower healing rate or slower healing rate or slower incorporation of the allograft itself.
Right. And it's I guess a curious question. If you had like a professional, NFL player, would you go towards like an allograft versus an autograft as far as like donor site morbidity? Like, are you more worried about, like, is there any different type of algorithm for, I guess, professional sports athletes compared to, your normal person that doesn't do a lot of physical activity? They're more, they don't do as much, rigorous work.
That's a great question. Professional sports is a whole different ballgame than the average person, as everybody knows. And so they're gonna be, their algorithm is going to be much more extensive from the get-go. And so obviously there's because there's all different types of injection therapies that will be involved potentially with them, including bone marrow aspirate or platelet-rich plasma or things like that. Their initial surgical management is probably actually going to lean more on the lines of debridement and chondroplasty and things like that, because in professional athletes, it's all about trying to be as minimal as possible when it comes to surgical intervention as you can, but as rapid as possible with any other type of intervention that gets them back onto the court or back onto the field as quickly as possible.
Right.
If that makes sense. And so their algorithm is going to be much longer and much more detailed before you get all the way to this level that we're now talking about in terms of osteochondral autografts and osteochondral allografts. And so that being said, Brian Cole, who's the head team physician for the Chicago Bulls, is at Rush in Chicago. They published a couple of good papers on athletes' return to play after osteochondral allograft. And they included not only a few professional athletes that he's done it in, but then also high-level college athletes and things like that. And the return to play after an osteochondral allograft is kind of similar to some other, cartilage restoration procedures. Is typically anywhere from 70 to 80%, generally speaking, which is pretty good, but not perfect. And so again, in a professional athlete, they're always looking for perfect. And so their algorithm is going to be much longer before you get finally to, this kind of end stage or end level treatment option, if you want to call it that.
Okay. And what is some of your experience with the autologous chondrocyte implantation for these types of pathology?
Yeah, so for cartilage restoration in general, it's a great procedure, and that we could certainly divulge into that heavily too on to another tangent. But just sticking with kind of the OCD theme for the time being, it's not as commonly done for OCDs anymore. For a couple of reasons that I alluded to and mentioned earlier. One being that there's a pretty significant subchondral bony involvement oftentimes, particularly with larger OCD lesions. And so if it's a smaller OCD lesion, either simple debridement and chondroplasty or the autologous transfer that we mentioned tends to be very adequate procedures for smaller OCDs. And if it's a larger OCD lesion, then oftentimes there has significant bony involvement in play too. And so then that's when people will frequently go to the osteochondral allograft transplant. Now you can do an ACI and with bone loss, and you can do bone grafting, and there's different techniques. There's a technique that's called a sandwich technique where you actually double up the graft to build it up or to bulk up the base of the defect. But it's not as frequently done, particularly at least as it pertains to OCD. But just generally speaking, ACI is it's a two-stage procedure where you do initial diagnostic scope and then you biopsy the articular cartilage, the patient's own articular cartilage. It gets sent off to the lab, and then those chondrocytes are cultured and expanded. Typically 4, 5, 6 weeks, and then those chondrocytes that are expanded are embedded onto some sort of matrix or some sort of graft. Oftentimes, the most common one that's done here in the United States is a matrix-associated autologous chondrocyte implantation, which is a porcine graft that the chondrocytes are embedded onto and into. And so then you come back for a second stage procedure, and then you cut that graft to fit the size of the defect, and then you implant it in to the defect or the defect base.
Right. So just to summarize that, so this, on autologous chondrocyte implantation, two-stage procedure. First stage, you biopsy the chondrocyte, send it in a lab, and then they culture those chondrocytes, and then you implant it, but you put it on like this collagen matrix. That'd be the MACI part of it. Then you put it on this collagen matrix, and you put it in the defect, and then on top of that, you like put some fiber and glue, or you suture it, or you just have some way to make it stay in place. That's kind of correct?
Yeah, that's right on. Nice work. Yeah, the historical way we used to do it was with a 6-0 suture. To suture the patch in. We don't usually have to do that as much anymore now. The fiber and glue that we have now is pretty good. In some cases, if it's a little unstable, we may put like a tiny little suture tack on the corners of the graft, and then suture it down with the anchor, with the soft little suture anchor, or something like that. But most of the time, yeah, the fiber and glue is typically what's utilized.
And what's the difference between this, where we have the two-stage procedure, versus I believe there's like another, just a one-stage procedure? I may be a little confused on it, but where you just have this collagen matrix is placed down instead of with the live chondrocytes. You understand? You know what I'm talking about? I thought.
Sure. Yeah. So there's a lot of different things that come out. It depends on what you're talking about, but yeah, so you can do like matrix associated stem cell, which or people call it that, which is where you have a collagen matrix, and you take bone marrow aspirate concentrate, and you basically inject the bone marrow aspirate concentrate back into the defect, and then you coat the matrix with the bone marrow aspirate concentrate, with the idea being that you'll have a large amount of progenitor cells and growth factors and marrow stimulants within that matrix and then beneath that matrix to stimulate the base of the defect. There's another procedure that's relatively newer too, where you can actually shave off some of the patient's own articular cartilage. So from those same areas where we talked about taking an actual graft or a whole plug for the oats earlier, you can actually just kind of shave the articular cartilage in that area, but then it gets grabbed with a tube before the shaver goes, before when you suction it up. And so you take all those fragments of articular cartilage, and then you can mix those also again with like a bone marrow aspirate concentrate into a paste, or put them even on a matrix, and then you implant that back into the defect. And so that's a single stage autologous, either matrix associated or matrix induced. Those are two separate ones, but two separate ways that you can utilize the patient's kind of own cells and then own bone marrow aspirate to do that in a single stage procedure.
Ah, okay. Makes perfect sense. Thanks for clearing that up. And then the last thing I wanted to touch base on, because I know we had a patient when I was on foot and ankle, we had a patient actually had this procedure done, and I never heard of it before. This patient is can you kind of talk about the Denovo procedures of those particulated cartilage products and like what that is, and I guess the role that it plays?
Yeah, sure. So Denovo is particulated juvenile articular chondrocytes. So PJAC, particulated juvenile articular chondrocytes, and it's cartilaginous tissue that's been minced up, and from a patient. Again, it's a donor, but a patient that's younger than 13 years old. So theoretically, it still has the capability to differentiate, or the capability to grow. Given where that stage is in the development process when it's harvested. And so it's particulated, and then you can put that in, and you put that in again kind of and then you put all the particulated juvenile cells in all at once, and then you can kind of glue that in as well in a similar type of way. And so that's had some decent data. The difficulty with Denovo is it is really hard to get through insurance in this country, in the United States, that is. And so it became popular about 5 or 6 years ago, and then it has gotten exponentially more difficult to get insurance to approve it. Occasionally, some insurance companies will approve it, or some patients will come in and ask for it if they have the means and the capability to pay for it. It is more frequently approved still in the ankle. For whatever reason, I think maybe just because there's a little bit more data actually for it in the ankle. But I personally, I'm a fairly busy cartilage restoration surgeon, and I haven't done Denovo in the knee in about 3 or 4 years. And I don't even try anymore, quite frankly, just because it's very difficult to get it pushed through insurance. But it's good that you got to see it for that ankle case, because they don't happen very often anymore. But that's what it is.
Right. Okay. And how do we, how do you decide? So I guess that's the one thing I still sometimes have trouble with. Like, how do you decide which patients are you're going to do a MACI versus a de novo versus autologous matrix-induced chondrogenesis? Like, I know these are all options, but how do you decide like which one you're going to use?
Yeah, that's a great question. Well, Denovo, they took that one out of, they made that one easy for us, because like I said, they've taken it out of our hands. Most insurances do, so they won't even get approved. So that kind of takes that one off the table, and in many cases anyway. When it comes to MACI versus an autologous procedure versus an osteochondral allograft transplant, again, it's patient specific, and all the factors that we always talk about in these types of things. So patient age, skeletal maturity, size of the defect, depth of the defect is a really big one, as we talked about earlier, and then to some degree kind of patient activity level and patient expectations and that sort of thing. And then the only thing that we haven't discussed as much, except a little bit, is the location of the defect. And so MACI has, the autologous chondrocyte implantation has really good results in the patellofemoral joint, somewhat better than historically like an osteochondral allograft or even an oats, just because the trochlea morphology can be somewhat difficult to match with an allograft or even an oats kind of graft. That has changed recently. We have some different types of cutting guides and some different types of techniques that now allow us to match allografts pretty much line to line perfectly in the trochlea. Same thing with the patella. The patella sometimes historically had issues with fixation, and the patella being very mobile could create issues. So historically, people have done some sort of an autologous procedure in the patellofemoral joint. I would say people probably do autologous versus allograft type of procedures in the patellofemoral joint about equally now in terms of cartilage restoration. But it did, for me, the big ones are patient age and expectations, but then especially the size, depth, and location of the defect.
Well, there it is. I think that's a perfect just kind of overview on all the different topics and I guess the just kind of the workup that you need to do for these types of injuries. I learned a whole lot with this, and I think we went over a lot of high yield topics that are asked about on different questions. So, thank you very much, Dr. Nuelle.
Yeah, this is
Uh,
great.
absolutely,
This is great.
absolutely.
Is
Yeah,
there
it's awesome. Thank you guys. Thank you guys for having me. I appreciate it.
is there anything I guess before we close out that you would say, that you'd want listeners to guys take away from this talk regarding cartilage restoration? Like, are there any big high points or that you can think
Yeah,
of?
sure. Yeah, I mean, I think the one big one I think I would say that you will hear probably most of your your sports attendings, if it's a resident or a fellow or anybody listening at that level or even beyond, or if you attend many of the meetings, you will hear people talk about microfracture a lot. And microfracture has historically kind of been the go-to number one surgery for any sort of a cartilage defect, or even whether it be an OCD or whether it be traumatic defect or just something that you see you happen to see incidentally for scoping a meniscus tear. It's very common that there will be an articular cartilage defect somewhere, even when somebody scopes for a meniscus or an ACL. And historically, people would stick a chondral pick in there and microfracture that and say it'll probably be fine and it'll be no big deal. But the literature is very clear that in many cases, particularly for larger defects, and especially for larger defects in younger patients, who are active, so our active patients less than 40, that is not going to be the case. And microfracture is going to break down, and it's going to break down usually within 2 to 3 years. And so I would just caution anyone, you may still see some attendings, and you may even hear some attendings in some places say that they still microfracture a lot of defects, and then patients do fine and it's no big deal. But you will not hear any high volume cartilage restoration attending tell you to microfracture very many defects. And so that's a big one that you'll hear us talk about a lot on the podium. We have much better options in 2020 for cartilage issues than just a standard good old fashioned microfracture. So I would caution anyone on that.
Fair enough. There it is. Good to know. But before we close it out, Dr. Nuelle, we usually ask our guests, is there a way for our listeners to reach out to you, whether it's a social media tag or email address or anything like that?
Absolutely. So social media, Twitter and Instagram is at Nuelle SportsMD. So NUELLE SportsMD. I'm pretty active on both Twitter and Instagram. I post a fair amount of cartilage restoration stuff on there, actually, for those that are really interested in that. Email is cnuelle, so CNUELLE at T as in Tom, SAOG.com. Happy to answer any questions anytime. Shoot me emails anytime. And then I'd be remiss if I didn't put in just one quick little plug for the podcast that we do too. It's called the Arthroscopy Podcast, and it's affiliated with the Arthroscopy Journal. And so certainly it goes right in line with you guys. You guys have a great podcast. And so for anybody that enjoys podcasts, check out the Arthroscopy Podcast and add it to your podcast library. And it's just more fun ortho podcast stuff. So
Love it. I love it, man. I appreciate you, Dr. Nuelle, for coming on. And until next time.